Good afternoon, everyone. So thank you all for joining today. As was mentioned, the title of my presentation is Alternate Level of Care Experience in High Risk Older Adults in New Brunswick, an Administrative Data Study. And so I'm Dr. Sandra McAllis, a Research Associate at NBIRDT, the New Brunswick Institute for Research Data and Training. And I'm really excited to be here to present some of this work that we did in collaboration with the Department of Social Development to help understand what is the experience of alternate level of care amongst their long-term care clients. So in New Brunswick, the Department of Social Development has a long-term care program in which older adults with functional limitations are enrolled or admitted to this program, and they are followed over the course of time in order to help support their needs. So there's different types of programs that are provided. Home care is one of them, as well as individuals living in special care homes here in New Brunswick, which is a home community-based facility that is a lower level than, for example, a nursing home, which we're often familiar with in terms of long-term care. So this population does not include nursing home population, but a community-based group of older adults who have functional limitations and have been admitted to this long-term care program. So just a little bit of a background. There was a mention about ALC, which I'll talk about. I'll speak the word ALC as opposed to alternate level of care. But just to be familiar with what that means, it's really a special designation that has been defined by the Canadian Institute of Health Information as a patient occupying a bed at a higher level of care than is required. So this really happens when an individual is admitted to hospital and they receive the care they need for that acute period. But then when it's time to be discharged, they no longer need that level of care. And so they either go home or may go to the special care home. But unfortunately, at the end of that hospital stay, where they came from is not sufficient to meet their needs at the end of that hospital stay. So oftentimes when there isn't yet a placement or a support system in place to help this individual transition out of hospital into a community-based location, they often have to stay in hospital until that is a suitable place is identified. And so this is an important strategy because it ensures that we keep individuals safe in hospital till we find good support for them. However, unfortunately, based on research, we have identified that ALC has important and significant negative implications for both patients and the healthcare system. So on the patient side, staying in hospital has been shown to lead to deconditioning, which is further deterioration of their physical condition, which, as you can imagine, is kind of contrary to what we would want to be happening in that period of time in hoping to have them better supported out of hospital. But this is also very costly to the healthcare system because it's using up a hospital bed, which you all know we have very limited of. And so the cost that's incurred in using that bed is not really an appropriate use of services because another individual could be in that bed, for example, someone who's waiting in the emergency room or someone who's in need of a surgery. So these things can cause backlogs in the system and then therefore inappropriate use of resources and patient outcomes, of course. ALC is really common among older adults. ALC does happen across the whole age range, but about 85% of older adults are representing that ALC population. And so that is a really important population to look into because we know that those older adults need support systems when they have certain chronic conditions or other ailments that may impact their functional status and their ability to live alone or ability to engage in activities of daily living in a safe way. And so this is especially important for older adults who have functional limitations that require supportive services, like those who are in the long-term care program that the Department of Social Development runs. And so those two programs are very common programs across many jurisdictions. And so the results of this work are also really important to help understand what is the picture in perhaps other places. And this is important because the research in this area is really limited. So when we engage in this project with Social social development in trying to get a better understanding of what is known about ALC, we were really surprised to find out that there wasn't too much research in this area, given that it's such an important problem. So really a better understanding of ALC can help to increase our insights into what might be going on with the goal of then alleviating this strain on the healthcare system, freeing up beds so that we can have them in place for those individuals who may be waiting for them. There are specific risk factors that have been implicated in the research that does exist. So research does find that women are more likely to have ALC stays in hospital following their acute stay. Those people who have lower incomes are also found to have be more likely to remain in hospital after that acute stay. Individuals who live alone. So these factors make sense. One of the main factors two of the main factors that are identified in the literature as roadblocks for ALC are really the need for higher level care associated with the dementia diagnosis, as well as waiting for a nursing home placement, a longer term care placement. So these are two factors that are really important that have been identified in the literature. So getting into the methods, the objective of this work was surrounded around three main objectives. And so as I mentioned, this was a partnership with social development. And social development, when we engaged in this process, was really interested in understanding how their long-term care clients were experiencing ALC, because ALC is data that comes from the Department of Health, and the long-term care data is data that is housed at social development. And so the ability to link those data within the secure facility at NBRDT provided that opportunity to do this research. And so the goal, primary objective, was really to understand and demonstrate the feasibility of this process. And once we did that, when we linked the data and put those different populations together, we used that information to explore the extent as well as the length of ALC hospitalizations among those long-term care clients. And we focused on a 5-year period. We ended in 2008 because when we applied for the data for the study, that was the last year that was available for both the long-term care as well as the DAD data, which is what we used for the hospital data. And then once we had characterized that information, we were trying to understand how did that hospitalization status differ among specific characteristics. So we looked at demographic factors, geographic factors, as well as long-term care program characteristics. So for example, individuals in home care or individuals in special care homes in different levels and different types, did they have a different experience with ALC? And so this is how we frame the project to help start to understand this problem. So this is just one step in the process. So I'm sure many of you who are here know what IRDT is, but I just wanted to put this out up front just to demonstrate to others who may not be completely familiar, but we are really a data center focused on supporting partners to turn data and information into policy and action. So I've highlighted three kind of key areas that we focused on for this specific project. So we used the data that was provided by Department of Health and Department of Social Development to do research that was guided through collaboration with stakeholders within social development, and we've worked with them to disseminate that knowledge and transfer it back to other key stakeholders who are directly involved in the research, and of course today talking all of you as well. So into the data sources and how we use these specific data sources. So we started with the Social Development Long-Term Care Database. And what this database does is it defines who is a long-term care client and their status. Are they active or are they applied? We focused on those who are active long-term care clients, but those who applied is also of interest to a broader research program. And we also looked at target groups. So target groups, maybe it's a familiar term to you, it was not familiar to me at the beginning, but this is a word that's used by the Social Development LTC program. And this is to define which program type you're in. So are you in home care, low? Are you in special care home, 3B? So there's different designations depending on the need of the individual applicant. We linked that data in identifying who are those long-term care clients over that 5 years. We then linked it to the Department of Health Citizen Database to get additional information on demographic and geographic information, because the Citizen Database is the database that houses data on Medicare card applications as well as renewals. And so whenever you move, you have to update your address. So this allowed us to identify where individuals were geographically located in the province to help understand a little bit about some of that differences across place, but also across demographics. And I should have mentioned all the program data for long-term care, of course, came from that first database. And then what we did was we linked those records with the DAD, which is the DAD Discharge Abstract Database. That's the Canadian database that records hospitalization discharges from acute care facilities and other types of facilities within the data in New Brunswick. We focus specifically on acute care levels of care in the DAD data, and we use this to identify acute hospitalizations among those people who we identified in the first database, as well as whether they had an ALC stay or not. So how do we find these people? We really wanted to include any long-term care clients who had a record, an active record between January 1st, 2013 and December 31st, 2018. So the exclusion criteria were any long-term care records that were associated with individuals who are under the age of 65. And so this is a legacy program that is still in the data. And so we removed these individuals just so we could focus on those who are over the age of 65, just to create a more homogeneous population. We also excluded individuals who were under the age of 65 at the time of their first case open, even though they had transitioned into another target group, just considering they may be a different population as well, and individuals who became long-term care clients after their hospitalization during that ALC stay. We did not consider, given they might also have a different trajectory of ALC than the typical long-term care client. So the data we're presenting today is really focused on what is the typical experience of a long-term care client in New Brunswick, and so focusing on this high-risk population. So how do we define hospitalization status? So each of these clients was grouped into one of three categories. They were either not hospitalized at all over the 5 years, they were hospitalized, but they didn't have an ALC stay. They just were acutely admitted and then discharged wherever they were expected to. But that wasn't data we looked at specifically. And then the third group, of course, that we were particularly interested in was those people who were hospitalized acutely, but then after that acute stay, they had some time, and we just considered any time as ALC stay. And so we define these ALC hospitalizations using the DAD and specific variables within the DAD data that are derived by the Canadian Institute for Health Information, or CIHI, and they're specific to length of stay. And so there's three variables, and the two that we specifically used is acute length of stay and ALC length of stay. And so these represent how many days an individual is designated in the acute care, and then how many days an individual is designated in that ALC stay. So of course, people who don't end up in ALC don't have an ALC length of stay. And so that's how we were able to define the three groups that I just discussed above. So any hospitalization that had that component, we categorized in that group. And so this is how we defined the three groups that you'll see predominantly throughout the presentation. So just a little bit of our statistical analysis is really a descriptive type of analysis. We're just trying to understand what is the prevalence in that specific population. So we use many descriptive statistics within this presentation. We don't do any statistical tests to say, is it different or not? It was really a first look to try to understand what was going on. We did do bivariate comparisons. So we looked at how hospitalization status differed by specific demographic factors, for example, marital status, language, as well as geographic factors, health zone, and some program characteristics, depending on the level of care or the social development region, for example. Okay, so now just getting into some of the results. So this is just giving you a sense of the distribution of the number of people, of long-term care clients, who were hospitalized or not hospitalized. So we identified over 21,000 long-term care clients who are active within that 5-year period at any point. And so 15,000 of them were hospitalized, and about 6,500 were not hospitalized over that period of time. When we translate that into proportions or percentages, but breaking up that hospitalized group, depending on which of the two hospitalization categories they fell into. Do they have a hospitalization with an ALC, which is that first red bar, or did they have a hospitalization that was only an acute stay with no ALC? And what we find is among long-term care clients, over a 5-year period, 25% are hospitalized with an ALC stay. 44% are not hospitalized but do not have an ALC stay, and then 30% of long-term care clients were found to not have a hospitalization at all over the 5-year period. So a higher percentage of long-term care clients were hospitalized than not hospitalized overall. So this is giving you a sense of the distribution of hospitalization status for each age group. So as you can see, there's not really a striking increase. We do find a bit of a difference across the youngest to the older age groups, which is expected. But overall, the proportions when we get into higher age ranges are relatively similar to one another. So we found that among those who are 65 to 69, about 20% have a hospitalization that has an ALC stay, whereas in those who are over 90, it's upwards of 26%. We have among the highest percentage in that middle category of individuals who are 80 to 84%, but these percentages in terms of the larger ones are quite similar to one another. So I mentioned I mentioned income was one of the risk factors or predictors of ALC stay. So individuals who, or in the research has been suggested, individuals who have a lower income are more likely to have an ALC stay than individuals who have higher incomes. And this may be related to the resources available to those individuals once they are discharged from hospital. We at IRDT don't have information on individuals' income, so we can't get that specific data. So in place of an individual's income, what we did was we use an area level proxy. So depending on where you live, that area is given a specific median income value based on Canadian census data. So it's updated every 5 years. And so that's how we assign. So depending on where the older adult lived, the value for that median group. So it doesn't represent that individual because most of these individuals are likely not working. So this is not necessarily a good proxy, but it gives you a sense that overall, we're not really seeing any differences in the area level differences for income across ALC stays. And so this was quite interesting as well to observe. Now just getting into some of the demographic factors, just showing you a few of the things that we did find. So I had mentioned that the literature does suggest females may be more likely to have ALC stays. In our data, among long-term care clients, we did not observe that disparity. We find that males had a 26% chance of being hospitalized over the 5 years as compared to 25% of females. Looking at language preference, this was taken from data within the long-term care database. And so we find that individuals who prefer the French language have a little bit higher percentage of ALC hospitalizations than those in English. And so this will also, you'll also see this when I show you some data across health regions. So we looked at marital status, and I mentioned as well that in the literature, it suggested that individuals who live alone or are single are more likely to be hospitalized requiring an ALC stay after that acute period. But we did find that those who are married had the lowest percentage of ALC, but this wasn't really that different from the other groups. And so single here represents individuals who are single, whereas other, maybe you're more familiar with other than I am, but other is another classification on the registration form that one fills out. And so this likely represents amongst this population individuals who are widowed or divorced, perhaps. And then the last graph on this slide is showing the differences across long-term care program type. So adult residential facilities are equivalent to a special care home. So that's a home in the community that doesn't have a nursing level of care. And so it's really community-based care. And in-home is support services provided by social development in the individual's home. So here we have a much wider gradient when we're looking across those two groups. So those individuals who are living in those community-based facilities had a 33% chance of being hospitalized over the 5 years, as compared to 20% in those who were in-home, receiving in-home care from social development. This is a bit to be expected because we know that as people have more functional limitations or more needs, that they are more likely to be placed in long-term care. So this was an expected finding. So as I mentioned, target groups is a word that's used by social development to designate what is a program type. So here we have divided up them according to those different program types. So I've kind of highlighted two sections here. The first at the top being those approved facilities, and then the second section being those in-home support services. So we'll focus here on the first section. As the numbers go up in adult residential facilities, which is what ARF stands for, the needs go up. So as we might anticipate, we might have increasing ALC. However, as the needs go up, the resources in the home also go up. So we don't observe a big difference in terms of ALC stay across these groups, but we do observe a really big difference across the percentage of ALC stay when we're looking within that in-home support group. So as I mentioned, there's different levels of in-home support depending how much time and resources are needed by the individual in their home. And as an individual moves through the long-term care program into higher levels of care, they really have this higher rate of ALC. So in those individuals who have low support needs, we only find about 11% have a stay with an ALC stay, as compared to 30% of those in the highest group of the long-term care program. Oops. Now, health regions is something that I guess is very salient to the Department of Health. So this is different regions that the province of New Brunswick is broken up into. So there's 7 health regions that we have as administrative geographies that we've represented here. So Moncton, St. John, Fredericton, Edmundston, Campbellton, Bathurst, and then Miramichi. As I showed you a few slides back, we found that those clients who had a language preference of French had among the highest higher ALC stay than those who preferred English. So we can see that in health regions that are predominantly French, we have higher rates of ALC. For example, the Bathurst region has among the highest rate at almost 33%. We found amongst all the health regions that the Campbellton region, which is in northern New Brunswick, and tends to be characterized by a high predominance of comorbidity and poor health behaviors. And so this is also interesting in terms of what we observed in the data. So across health regions, we observed a substantial difference, with Fredericton having the lowest, which was under 20%. So the distribution here was also quite interesting and will be interesting to continue to explore. So now I've showed you how the distribution in terms of the hospital status is, but now to get a sense of like, okay, well, these individuals are being hospitalized, but how long are they staying in hospital? So as I mentioned earlier, there's 2 phases or components of a hospital stay. The acute care component, which is a typical component that we all experience if we're admitted to acute care in hospital. But again, when individuals cannot go home or to the place where they came from, they often will, they can need to remain in a hospital because they have no suitable placement for themselves out of hospital. So this slide here is focusing or this graph here is focusing specifically on the number of acute care. So the red line represents the median number, and then the top line and the bottom line represent the interquantile range. So that gray area really represents about 50% of the long-term care clients. So what is their, can we characterize their hospital stay? So among acute care, people who were hospitalized and then had an ALC period during that hospitalization, they were hospitalized in acute care for a median duration of 10 days. And you can see that that distribution is quite more variable, as we may expect, because these people have various needs, and that's maybe what's leading them to, or higher needs, and that's what's leading them to need a ALC stay, but also the various needs may represent different times within that acute stay. In individuals did not have an ALC stay as part of that acute care, they were a lower median duration of stay at 6 days, and a less variability in the distribution. So now when we look at those people who are hospitalized but then needed ALC, how much time do they spend there? So we found that long-term care clients were spending a median of 14 days in alternate level of care over the 5-year period. And so in total, about a month or 24 days, if we add up those median, about 50% of long-term care clients are spending in hospital. So I presented the median in the previous slide because length of stay is a variable that is extremely variable. So there's a lot of differences across length of stay, and there's some people who stay in hospital a very long time. So when we present average values, they're a little bit skewed because of that skewed distribution. And so they're not necessarily as representative of the data we would want to observe. But when we break things up into groups at IRDT, it becomes difficult to release certain data points. And so oftentimes we're left to release the average value in place of the median. So this is why we've presented it here, but I just wanted to put those caveats there. Overall, what we do find is the length of stay is much longer in individuals. The ALC length of stay is much longer in individuals who are in approved care facilities, so those community-based homes, versus individuals who are in-home, receiving in-home support. And again, amongst the in-home support groups, again, this is at the top, it's switched, I'm sorry. We see the low in-home group is having the shortest ALC stay, and that increases as we increase the need in the home support. All right, so now just finishing off with the discussion section. So just in summary, I did go through a lot of data over a short period of time. So really our first objective was to demonstrate the feasibility of linking these data and addressing an important policy question for stakeholders within government. So we were able to link data across departments, and it allowed us to examine the ALC experience, again, which is Department of Health data, among social development's long-term care clients. And so this really higher risk population, individuals or older adults who have functional needs. And so the data that I've used today is accessible to the research community through a very rigorous approval process at NB-IRDT, but please reach out if you have any questions. A quarter of individuals with functional limitations that require supportive services, either at home or in a community-based facility to maintain their independence, they're acutely hospitalized, followed by ALC. And the median stay for these individuals is nearly a month in hospital, and half of which time is in ALC. So as I mentioned, when we first started this presentation, the time spent in ALC leads to patient deconditioning, and so they may be worse off at the end of that stay. We didn't really observe very major striking differences across specific socio-demographic characteristics, such as sex and marital status, for example, or geographic characteristics, though we did find a bit of a difference, for example, between Fredericton and Campbellton. We were more likely to observe differences when we looked at program-related characteristics, which was expected given the needs are greater as as the level of care increases within the long-term care program. So individuals that were living in supported community housing had the highest rates of ALC during the study period. And this is likely representative, again, of that health burden or individuals with more comorbidities that it's more difficult to manage in the previous level of care that they were in prior to entering hospital. So as I mentioned as well at the beginning, research on ALC is very limited globally as well as in Canada. And so robust estimates are not readily available to be able to compare with the estimates we have. There are limited number of studies that focus on special older adult populations, such as those receiving home care, but in other jurisdictions. So there is some evidence, but it hasn't necessarily been generalized to other populations. So in the general population of older adults, specific factors have been found to predict ALC stay. So lower income, a female, living alone, a single marital status are all found to have higher rates of ALC in the literature. Based on our research, we found that perhaps community-based support programs may mitigate these disparities that are observed in the general population across disadvantaged socioeconomic groups among older adults that are higher risk. So older adults with different characteristics enrolled in this long-term care program had very similar likelihood of ALC. So that ends my presentation. I just want to end off by thanking you for joining today, and I hope you enjoyed the topic that I discussed and the results that I showed you. And of course, I would like to acknowledge our funding partners and our support network as well. So thank you so much.